Okay, and welcome back to today's webinar on anti-inflammatory and immune effects of laser therapy. My name is David Kunashko. I'm the Director of Education and Training, a bit of research on the side and some bottle washing here as well at Meditech International out of Toronto, Ontario, Canada. And we, of course, manufacture Bioflex brand laser therapy devices. So I want to thank everyone for showing up today and listening in for the next half an hour. I'm going to talk a bit about the anti-inflammatory and immune effects and trying to explain this as best I can. The reason why this is so important is that when it comes to laser therapy, which really the term is now referred to as photobiomodulation, a lot of clinicians don't really understand the effects of what they're doing with the light, and they don't understand how to achieve not just a healing effect, but an effect on the immune cells, which of course govern and control inflammation and other aspects of healing in the body. So to best be able to treat your patients, not just directly for injuries and lesions and so forth, but actually to have a systemic effect around the injured area or the diseased body, this can be highly important. And in fact, it was one of the first things that Andre Mester noticed back in the 1960s when he first serendipitously discovered low-level laser therapy. So before we start, just a reminder, this webinar is being recorded and that you can listen in on our archive support page when you have a chance within a week or so. And you also receive an email after the webinar if you registered in order to listen in or join the link to listen in at your convenience as well. If you have any questions, please type them in as we go along. At the end of the webinar, I will have time to go over these questions. So I'm going to first present an overview of the immune system and the inflammatory pathway. Maybe it's been a few years or a few decades in my case since you were taught this information. So I think it's a good review to understand what's going on in the human body. And then I'm going to get specifically into actually how LLLT or photobiomodulation really affects the immune system and how it can help to decrease inflammation in the body. And there is a huge amount of research in this field. I'll present some of that research to back up the points I'm making. And then I'm going to talk specifically how you can achieve this immune effect. And really, it's done via intravascular LLLT. And I will explain that and how we use Bioflex to achieve intravascular low-level laser therapy. This concept itself might be a little new, probably new to a lot of people here. However, it is something that's been well established in the literature, but just not really well established in the clinical research human trial end of things. And I'll explain that as well too. And lastly, we'll have time for some questions and answers. Okay, so this picture is taken from the website below. And we of course know that the immune system is divided into the innate, which is your first and sort of second response. Consisting of your skin and barriers, and then tissues like salt and malt that have and can release neutrophils and macrophages. So this is really your first line of defense that initiates inflammation, gets it going, and then helps to resolve it. And I'll talk about this procedure as the webinar proceeds. And then, of course, there's the adaptive immune response, more the tertiary kind of effect, long-term effect, and typically for when the innate system does not work properly or is ineffective, for example, a viral infection or bacterial infection, systemic infection. And this, of course, are your B lymphocytes, antibodies, T lymphocytes, and so forth. So everything from cancer to infections, that's where the adaptive immune response comes into play. However, I'm going to really concern this talk today more with respect to the innate, and especially with respect to neutrophils and macrophages and the both anti and pro-inflammatory effects of this innate pathway and how LLLT can actually help to modulate it in a very positive way. So let's take tissues that are injured. So this could be a sprained ankle or what have you. The first thing that's going to happen in the site of injury is that there'll be a release of specific chemicals that are released into the bloodstream. This will cause a whole series of different effects, everything from widening of the blood vessels and increased permeability to allow to allow neutrophils, white blood cells, to leak through. And the widening of the blood vessels brings, of course, lots of blood in circulation, causing redness and heat to the injured area. And of course, we have along with that is swelling. Then there's secretion of prostaglandins and other chemicals that cause pain to tell the body that we have an injury. And then, as I mentioned, with the migration of white blood cells, this will lead to a whole series of interactions that initially initiate inflammation and then go to town to clear out the damaged cells and material, and then start to promote new cell growth, fibroblast response, and repair of the damaged tissue. So that's a kind of a schematic of what's going on. So again, let's take a sprained ankle, for example, on a bit more of a microscopic level. We initially, as I mentioned, have capillary widening or vasodilation. This will, of course, lead to increased blood flow in the area, which initially is very profound and quite important. Subsequently, the permeability of the capillaries is increased. This allows fluid to be released or secreted through the capillaries, causing edema and swelling. All of this will be leading to heat and redness as well. And then, as I mentioned, the white blood cells start to migrate. Initially, it's initiated by neutrophils, followed by monocytes, which turn into macrophages, and there may even be a systemic response as well. So all of this will lead to the cardinal signs and symptoms of inflammation, as all us clinicians know and despise. So on an even more microscopic level, remember that neutrophils are your first responders. They're very important for phagocytosis and clearance of dead and dying tissues. So extremely important with respect to that first response. It's considered really initially sort of an anti-inflammatory type of reaction, or sorry, a pro-inflammatory reaction. It's what gets the inflammation going. Soon after that, monocytes start to leak and are attracted through chemotaxis to the injured site. And these monocytes are rapidly converted into macrophages. And there's two types of macrophages, M1 and M2. M1 is a inflammatory promoting macrophage, and M2 are anti-inflammatory macrophages. This is really important with respect to the progression of the injured tissue. And again, I will explain this as we go along. The other important aspect is the release of growth factors, which helps new blood formation, initiates and promotes fibroblasts to turn over, secrete collagen, mucoid material, and the repair process. So this is essentially what's going on in the injured area. Okay, so I'm going to sort of walk through some schematics here. The first thing I mentioned are neutrophils are released. This will lead to prostaglandin secretion that causes pain, a cytokine release, and reactive oxygen species release. These spike, and this will lead to cellular damage. And over time, macrophages get involved. They start to release cytokines that are anti-inflammatory and promote tissue repair. So there's a balance between the initial neutrophil influx and the macrophage influx, and going from M1 to M2 macrophages and initiating tissue repair. So that's what we want to happen, and we want this to happen as soon as possible, and we want to accelerate this process, which is why we're in business. As clinicians, we're trying to repair as fast as we can and help the body improve this. Everything from manual therapy to other types of therapies to nutrition, this is all part of the process. So the question begs, how does LLLT decrease inflammation? Well, let's look initially at the neutrophil influx followed by macrophages. There is a fair amount, actually probably hundreds of papers, research papers, that show that LLLT can increase macrophage influx to an injured area and decrease the neutrophil influx to the damaged area. This, of course, will help the damaged cells repair themselves faster, and in the cases of chronic inflammation, can restore the inflammatory process to more of a progressive inflammation where you get the resolution of the injury as opposed to a chronic inflammatory phase. The other aspect that light seems to have on, especially on neutrophils, is it reduces oxidative stress, which are those reactive oxygen species that as they spike very high, they actually cause tissue damage, especially damage to the mitochondria, and this will lead to cells to undergo cellular apoptosis or cell death. Light therapy actually helps to repair that and reduce those high spikes of ROS. And this, of course, will lead to decreased apoptosis or cellular death and help those cells to recover at a much faster rate. With respect to cytokines, these are chemicals like interleukins, and they all have different numbers, of course, and some are pro-inflammatory, some are anti-inflammatory. And the research has basically shown that LLLT can promote and increase the cytokines that help inflammation to resolve, that is anti-inflammatory cytokines, and it decreases the pro-inflammatory cytokines. Cytokines are interesting because sometimes they increase and sometimes they decrease inflammation, even the same cytokine. It all depends on the chemical environment in the area. So there's a balance. If the balance is shifting towards pro-inflammatory cytokines, the tissue remains inflamed. If it's shifting towards anti-inflammatory cytokines, you start to get the healing response. Another way that LLLT is very helpful with respect to pain is it reduces prostaglandin release, in part because it has an impact on neutrophils and decreases the activity of neutrophils, so therefore you have less prostaglandins in the area, and this can of course help pain. So this is really critical in helping your patient get through the pain associated with their injury as well, as opposed to taking a medication or some type of drug to help relieve with that. So let's take a look at the research, and there's plenty of research. It was difficult for me to choose just a handful of papers considering the volume of this type of information, but I chose a few that I think are really quite good in showing the positive characteristics of LLLT. This particular one talks about the effects of light on ROS by human neutrophils. So neutrophils secrete ROS, and initially they secrete a lot of reactive oxygen species, and as I mentioned earlier, ROS is a very toxic substance. In essence, it will actually trigger cells to die. So the purpose of this ROS is to sort of get tissues that are dead or dying, get them out of the way, and then help to resolve that. So tissues with active inflammatory conditions histologically are characterized by considerable neutrophil infiltration. And this ROS, as I mentioned, can impair proteins, the production of DNA, RNA, and we know it has a huge role to play in almost all inflammatory conditions going on in the human body. This particular study looked at, excuse me, 830 nanometer continuous wave light, 150 milliwatt per centimeter squared. So that was the power density. Notice the wavelength 830. The wavelengths are really important in LLLT. I'm sure many of you are aware of that. There's a lot of misinformation about these wavelengths, and that's another topic for another day. But we know 830 is definitely a wavelength that is in the wheelhouse for helping these cells recover. They found that when they irradiated neutrophils, now this was done in vitro, with 830 nanometer light, they found that you could attenuate or decrease ROS production by these neutrophils. So in other words, if you expose neutrophils to this wavelength at around that power density, it decreases the production of ROS. And that's of course a positive when you're trying to make an area reduce its inflammatory response and help the progression towards the resolution of inflammation. Another paper looked at the biological effects of red light, in this case 632.8 nanometers using a helium neon laser, and again looking at this time at mononuclear cells in vitro, so again in a test tube. Recall that monocytes make up about 5 to 8% of the total population of white blood cells in the blood. During wound healing, monocytes are critical because they actually, through chemotaxis, migrate to the injured area. Then they turn into macrophages. And as I mentioned earlier, these macrophages have a great effect on the immune response. So if you can influence the numbers of monocytes and their activity, you can help with the proliferation of the healing cells like fibroblasts, which of course help in the whole aspect of wound healing or healing of tissues that have been injured. So they found that red light at 630 nanometers, give or take, helped increase the proliferation of peripheral blood mononuclear cells. And of course, this would therefore increase the supply available to turn into macrophages, which then help the healing process. So light will increase the numbers of monocytes, the numbers of macrophages, and their activity, which pushes the inflamed area towards the healing side of the spectrum. So here's a little chart to show you what's going on with respect to monocytes. As I mentioned earlier, monocytes will be transformed into M1 macrophages and M2 macrophages, and an M1 macrophage can turn into an M2 macrophage. Now, if you look at what's going on, M1 macrophages, their functions are pro-inflammatory. So they're critical for helping killing bacteria, for engulfing bacteria and viruses in an area. So they're really important, and like cancer cells, they're really important to protect an area. So that's important if you have an infection or what have you. However, if you have tissue damage, you really want macrophages that are more anti-inflammatory, produce matrix, help promote blood or flow or through angiogenesis or promoting blood formation or capillary formation and promote wound healing. So M2 is the preferred macrophage we want at the site. And they also secrete anti-inflammatory cytokines, all these different interleukins, anti-inflammatory chemokines, and growth factors that stimulate the healing process. I saw a question earlier about stem cells and light therapy. The whole idea with stem cells is for them to release growth factors and these positive spectrum of chemicals that are going to help promote tissue healing. So it actually is indicated to use light therapy along in conjunction with stem cell therapy. There's not a lot of research on that, but there is. So they're not actually saying to do light therapy weeks or months later. They're actually saying to do it in conjunction with. Okay, so we want M2, not M1. Everyone got that? All right. So what are the effects of light therapy on macrophage phenotypes? In other words, on M1 and M2. So it's interesting property that, as I mentioned, that these macrophages can be converted from M1 to M2 at the injury site. And yes, research has shown that both red and infrared wavelengths stimulate the formation of M1 to M2 macrophages. And of course, this is the anti-inflammatory macrophage we want at the site. So in other words, LLLT promotes M2 activity, which then promotes directly anti-inflammation, angiogenesis, and tissue healing. Now, there's been quite a bit of research in this particular area, and what they've concluded was that it's lower energy densities, anywhere from 1 to 10 joules per centimeter squared, that seem to have the best overall effect on decreasing inflammation. Remember this range, 1 to 10 joules per centimeter squared. Now, earlier I mentioned milliwatts per centimeter squared. Milliwatt is a power, so that's power density. This is energy density, that is joules per centimeter squared. So the research shows that if you have light that is in this energy density, it seems to have the best anti-inflammatory effect. Okay, so that means that if you're throwing tons of energy at the area, you will be well above this 10 joules per centimeter squared, and it's shown actually to have more of an inhibitory effect, and that's not what we want. Here are my references for that material that I just mentioned. And if you want to write these down, you won't have time right now, but you can do so when you rewatch the webinar if you choose to do that at a later date. Another paper looked at macrophage response to light therapy. Mary Dyson is Professor Emeritus over in the UK, and she is one of the premier, was one of the premier researchers in the field of LLLT. and they discovered that specific wavelengths like 660, 820, 870 encourage macrophages to release those anti-inflammatory mediators, cytokines, and promoting growth factors that help stimulate fibroblast proliferation. And certain other wavelengths inhibited higher wavelengths. Okay, so again, wavelength can be important with respect to how these cells are utilizing the energy. So can LLLT help autoimmune diseases? There is not a ton of research in this field. However, there is some. And anecdotally, certainly in our clinic and from talking to other practitioners, LLLT has been used in treatment of conditions like multiple sclerosis, which they feel is an autoimmune disorder, rheumatoid arthritis, and so forth. And the research tends to not just believe, but actually show that LLLT can actually help the progression of these autoimmune disorders. This particular paper looked at a mouse model of multiple sclerosis using autoimmune encephalomyelitis, or EAE in mice. They used 660 nanometers. They used 904 nanometers. That wouldn't be my choice, but that's what they used. 10 joules and 3 joules per centimeter squared. They treated along the length of the spine of the mouse on either side for 30 days, so every day consecutively for 30 days up and down the spinal cord. And from this paper, they showed your little mouse here and where they were sort of zapping it along the spinal cord, and they found that the effects were quite positive. It had an autoimmune response such that the neuroinflammation was decreased, and everything from the weight loss was improved. There was a decrease in nitric oxide levels. This is beyond the blood-brain barrier. Neuroinflammation was decreased. The severity of symptoms as monitored in the mice decreased, and even the lesions, the demyelinating lesions, were decreased. So they basically hypothesized from this research that the effects of LLLT can pass the blood-brain barrier and get into the central nervous system, and that is because these are chemical mediators that are transferring this positive effect. So it's not the direct light that's achieving this, it's the indirect light on the blood. So what I'm talking about here is promoting light absorption by the blood, which will then be carried into the other tissues systemically. And this is very different than having the direct light respond on tissues that are injured. So they concluded that LLLT applied daily post-EAE induction mice that inhibited the clinical signs, neuroinflammation, and so on and so forth that I just mentioned earlier. There's 1 or 2 clinical trials as well that showed it was effective in treating multiple sclerosis patients. Okay, so how do we go about treating blood? This type of treatment, the term, there's different terms, but intravascular LLLT is probably the term that's most accurate. And there's different ways of achieving this. One is to apply a fiber optic fiber to a needle and then insert it through the skin into the vein. And as the blood courses by this fiber optic, then of course that blood will be irradiated directly. Now, in Russia, some other countries, they tend to do a lot of intravenous LLLT. However, in most other parts of the world, as it is invasive, as it can only be done by typically physicians or naturopaths or people that are doing IV type of therapy, it restricts this type of therapy to very few people. And of course, a lot of patients aren't overly eager to be punctured, especially if they're kind of new to this type of therapy. However, it can be a very effective way of achieving blood irradiation. Another way that's been postulated is through intranasally or through mucous membranes. And there's been devices out on the marketplace that typically try to do this. And not a lot of research on this. The downside, of course, is the fact that the light isn't necessarily touching the mucous membranes directly, so a lot of that light will be reflected off, and the surface area and the absorption rate would be pretty much minimal because you're not treating a very large volume of blood. Of course, you are closer to the brain, so perhaps that is one positive aspect. But as far as the amount of intravascular therapy you can achieve through the nose, would, in my opinion, would not be as optimal. How we achieve this with our equipment is transdermally. So in other words, going through the surface of the skin using a very large surface area of light, for example, our dual arrays, positioning them directly on the skin so that you minimize reflection of the light and maximize absorption, especially in the cutaneous and subcutaneous tissues that harbor the blood that you're trying to treat. So our equipment is designed to do transdermal intravascular light therapy. That is essentially what we're achieving with these large arrays. We're trying to stimulate the anti-inflammatory and immune effects around the injured tissue in order to have that systemic effect that we desire. We, of course, also use a much more powerful laser probe to penetrate even deeper to directly affect tissues that are damaged. But this is trying to achieve the anti-inflammatory and immune effects. Okay, so let's take a look at how we achieve this. Recall, as I mentioned earlier, the research indicates that it's the lower energy densities that seem to have the best overall anti-inflammatory effect. So in other words, low and slow. So what does this mean? Well, unfortunately, we're going to have to do a little bit of math. So if you look at the equation here, you end up looking at pi. Homer thinks that's a pi as in what he's going to eat, but of course we know that is 3.1415926. All right, so we look at a joule. Joule is a watt times a second. So for example, our Bioflex Dual Plus 240 array, the red array at 100% power, continuous wave is 1,000 milliwatts or 1 watt. The surface area is 75 centimeters squared. So if we treat for 6 minutes, which tends to be the average amount of time that we treat one specific area with the array, the number of joules is watts times the seconds, which gives you 360 joules. If we want to convert that to energy density, which is often how it's reported in literature, then we divide by the surface area. That gives us 4.8 joules per centimeter squared. And remember, I said the optimal amount of energy density for anti-inflammatory effects typically seems to be in the range of between 1 and 10, and we're at 4.8 joules. So we're in that sweet spot for anti-inflammatory effects. Now, we of course also have an infrared component to our equipment, which has twice the amount of power, or 2,000 milliwatts or 2 watts, same surface area. So for the same 6 minutes, the joules would be 2 watts times the time, 720 joules. Same surface area, that gives you 9.6 joules, which again is looking in that range of 1 to 10. However, most of the time we're going to modulate this light and pulse it out. Oftentimes we're at duty cycles anywhere from 10, 20, 30, 40, 50%. So for example, at 50%, then of course we would multiply that energy density by 50%. And of course that would give us a 4.8 joules per centimeter squared. Again, a really nice energy density to treat that area. So when we combine the two, we're still typically under that 10 joules per centimeter squared. That seems to be the optimal amount for helping with inflammation. So when we treat the neck, when we treat the hip, we are trying to also stimulate the anti-inflammatory effects by treating the blood around the damaged tissue. So a hip arthritic joint, a disc herniation, a facet injury. And by stimulating that blood, and we know that that blood will now carry those positive effects deeper to the deeper tissues where the injury is taking place, and will have a profound effect at reducing the inflammation and progressing that inflammatory phase to the repair phase and helping with the injured patient. We do have specific protocols for inflammation. If you look at stage 1, for example, The red is either continuous wave or we pulse it out at 50% duty cycle. Notice that the duty cycle starts pretty low at 30%, with the frequency also pretty low. When you look at the total time and the duty cycles involved, the total amount of energy density will still be well under 10 joules per centimeter squared, or what seems to be the optimal amount of energy density for anti-inflammatory effects. The same token, the immune response, autoimmune conditions, we actually have a little bit longer treatment times. However, the duty cycle tends to be lower, especially for the red. So the overall energy density, even though it's longer treatment time, is still within that 10 joules per centimeter squared. And the fact that we have it on for even longer helps to trigger that response even more with respect to the effect on the white blood cells and the immune system. So you can almost equate this to putting a needle, fiber optic needle, into your vein and try to stimulate the white blood cells in the blood. But we're doing this transdermally over a much larger surface area to be non-invasive, and from what I've read, what I've seen, to have as equal effect, if not even more powerful effect, than an IV light therapy. All right, well, listen, thanks everyone for attending today's webinar. I will pull out the questions and I will see where we're at with that. So, I have one question. Is it okay to treat two separate areas of the body at the same time using two different arrays, say two inflamed hands at the same time? It is perfectly acceptable to treat multiple areas at the same time. The systemic effect, although I say it's systemic, it's most powerful in and around the area that you're treating. Yes, some of that effect will go throughout the entire body, but it's most profound in and around that area. So you won't overdo it by treating multiple body areas. How about using photobiomodulation directly on the gut brain using the Duo Plus or personal system at the stomach or intestines or abdomen? Again, I've never seen any research on that, but to me it would make sense that it might help with the overall inflammatory effects. Anecdotally, treating patients that have had conditions, inflammatory conditions of the gut, like Crohn's and irritable bowel syndrome, even conditions like endometriosis, we've seen improvement of symptoms, and I can relate the improvement probably due to this anti-inflammatory effect. Another question is, I'm wondering if I can speak briefly to the potential application of Bioflex infrared or red for chronic Lyme disease. I've seen a little bit of research on Lyme disease. I've known anecdotally, we've treated some patients. I know other practitioners have treated Lyme disease, and I think there is potential for that. However, I just don't have a lot of clinical experience with Lyme disease. But again, based on probably there is an inflammatory component going on in the body, that it would make sense, and an immune component, perhaps even autoimmune by that point, that it should be helpful. So I would say that it would certainly be something to try for sure. If inflammation is a natural response, why do we want to decrease it? Well, basically, inflammation is a natural response, of course, but the body's response to an injured tissue or to diseases tends to be on the extreme side. Our body's never really adapted to inflammation with respect to the bare minimum. It's always the maximum amount of inflammation response, which, as we know, can actually be prolonged to involved and very difficult to resolve. So in those patients where you're having difficulties resolving inflammation, everything from complex regional pain syndrome to sprained ankles that are healing quickly, it has to do with the body not properly resolving the inflammatory response. So by helping that body push through the inflammation and start to resolve it, you'll get the healing component quicker. So inflammation kickstarts it, but we don't want to have a prolonged inflammatory response, which for many patients, that's what happens. How about an anti-inflammatory response in people with generalized inflammation like autoimmune conditions? Again, there is research to suggest, as I mentioned earlier, that on even generalized inflammatory conditions, that if you treat the blood with LLLT, it can be very helpful. So NSAIDs, question from Jill. NSAIDs work by reducing production of prostaglandins and for reducing pain. LLLT does the same. We're supposed to suggest to clients not to take NSAIDs as they slow down the laser effect. If both reduce prostaglandins, how exactly does this cause a problem with the laser? Okay, so Jill, that's a great question. I'm going to have to look into that a bit more, but from my understanding is NSAIDs work on a very different level with respect to prostaglandins. LLLT is not a chemical barrier to prostaglandin production, so it doesn't prevent the enzymatic release of it. It actually has an effect on reducing the activity of the cells that are releasing prostaglandins, like neutrophils. So in other words, the prostaglandin release is modulated by LLLT from the cell by reducing the function of that cell, as opposed to a chemical block or blocking of an enzymatic reaction by a drug. What if the patient has cancer? LLT is contraindicated to treat directly over cancer, only because we're not quite sure of the effects of LLT for cancer. Can LLLT cause chronic idiopathic neutropenia? That's a good question. The effects of LLT are transient. So in other words, they're not going to promote, and everything I've seen, they're not going to promote a chronic neutropenia condition. If you have inflammation caused by an infection, so you don't use LLLT, or do you use different energy density? Generally speaking, LLLT is not prescribed to treat an infection. However, when you're treating wounds, oftentimes they are infected, and we do treat wounds with LLLT, and it seems to have a positive effect on the infection, but it's not indicated for it. So that's a slippery slope, because legally and regulatory wise, it's not indicated for infections, but you can read between the lines. Oh, and Lauren Brown has joined us from Vancouver. I thought it's 100 centimeters squared, not 75 centimeters squared for the 240 array. Oh, that's a good point, Lauren. I may have gapped on that. I was thinking of the 180. That is correct, Lauren. That is 100 square centimeter, not 75 square centimeter. And I thank you for Lauren for showing me that my math was wrong today. But it still was good enough to prove my point. Rob, does the personal system have the proper energy density for decreasing inflammation? Yes, it does. With rheumatoid arthritis, would you place along the spine, such as the example in the mouse, or specific areas? Jill, we typically treat around the affected area of the rheumatoid arthritis, trying to treat both locally and that systemic effect around that area. But you can also treat other areas just to promote the autoimmune effect. That could be behind the knee or other areas where there's good blood circulation, to try and get an even better systemic effect. For autoimmune diseases, what would the outcome be if you treat the cisternae cheli in the abdominal area? I'm not sure. That's a good question, but I don't know how the answer for that. What about using the laser after the arrays? Won't that increase the dose past the optimal level? Well, that's a really good question. However, because we're using a much smaller surface area, 0.1 centimeters squared for a laser probe, the bulk of that light will be traveling past the blood and into deeper tissues that haven't been overly affected by that dual array. So you won't, in fact, have that kind of negative effect of overdosing using the probe. A frequently asked question, I used ankle foot protocol for a Jones fracture. I had it re-x-rayed today and it's healed. Awesome. Evelyn, that's good news. My son just fractured his first metacarpal. He's in a cast, so unfortunately I can't get to it. Any research on chronic fatigue syndrome? Geez, I don't know if there is, Gretchen. Please email me and I can see if I can find any for you. How many treatments would you recommend for a neck, low back injury, mild to moderate sprain strain as related to this? Typically, mild to moderate strain sprains, of course, a strain heals faster than a sprain. So you'd be looking anywhere from, on a mild side, 6 to 10, on the moderate side, 10 to 20. And you would, of course, expect a little bit longer if that was a sprain. is the word on treating patients with known cancer still that it's contraindicated? Again, it's contraindicated to treat directly over an area of known cancer, but not away from the area. We don't have a protocol for reflex sympathetic dystrophy. However, we tend to treat both the affected spinal area and the actual the spinal region that innervates the affected area as well as the affected area. We also use much lower dosages to treat RSD over the affected area. I would like to show this webinar to my wife and to a friend who is wondering what to do. Can I copy this? You should receive a link to the webinar to watch at another time. How many sessions are required before we could expect a result for chronic tendinosis? That's too general of a question, Christina, although I appreciate it. There'd be lots of other things you should be doing as well, but usually tendinosis start to improve within 6 to 10 sessions as a rule. All right, Lauren, I will see you next week. I will be attending a infertility conference next week in Vancouver to co-present with Lauren Brown, Dr. Lauren Brown out in Vancouver. So if you are out that way and interested in fertility, it would be a great seminar to go to. Is there any evidence on autoimmune vasculitis conditions and the lung? Actually, there is evidence about treating lung conditions, a lot in animal models and not so much human models, which is a problem because animals is easier to get light to. But I think if you had the right dosages and treated around the lungs, you could have an effect. Last question on Meniere's disease. We do treat Meniere's, and there is some research, clinical research on Meniere's. Seems to indicate that it can be very effective, but you do have to get light closer to the inner ear, which poses a problem. Which means you'd have to use a little bit higher energy density, that from a laser probe. Thanks everyone for attending today's webinar. I will be putting out the list for the next few webinars shortly, and hopefully you can join me then. Take care and have a great day.